Okay, so the first of the anxiety disorders that we need to talk about is generalized anxiety disorder, also known as GAD. Okay, so the big thing before we get into specific symptomologies for generalized anxiety disorder is to remember it's just that, all right, is anxiety, okay, it's worry, it's nervousness, it's tension, all right. But unlike most normal contexts, if you're nervous and you're worried, I can say to you, what are you worried about? And you can tell me. All right, I'm worried about my relationship with my boyfriend, whatever it happens to be. Okay, and then we can resolve that because we have a specific thing that you are concerned with. With generalized anxiety disorder, the individual can't put their finger on to what it is they're concerned about. Hence, it's very difficult to treat, all right, because they have generalized anxiety. Everything seems to upset them. Everything seems to worry them, okay? So what do we get? We get persistent and uncontrollable tenseness and apprehension. Okay, the key here is it's persistent. It's all the time and it's uncontrollable. It's something that you can't calm yourself down from. Okay, you get autonomic arousal. So in other words, you get stomach is upset, heart rate's up, blood pressure's up, sweaty palms, etc., etc., etc. Okay, and the inability, of course, like we mentioned already, to identify the cause of certain feelings. Okay, so the question there is, how is this similar to Freud's theory of repression? Remember, Freud talked about the idea of repression is we forget and we forget what we forgot. Okay, a lot of cases of generalized anxiety disorder are actually caused by that. All right, because we take something that we're worried about, a traumatic experience, and what do? We bundle it up into a nice tight little ball, we shove it deep down inside of ourselves, and then we think that that's going to help us deal with the negative emotions associated with that, and so we forget about the event. All right, we forget and we forget what we forgot. It continues to cause us psychological as well as physical symptomologies. All right, so a lot of cases of GAD can be associated with Freud's theory of repression. Next one we need to talk about is panic disorder. We've mentioned this in one of the previous discussions we had. Basically, this is a minute-long episode of intense dread, which may include feelings of terror, chest pains, choking, or other frightening sensations. Okay. Remember, the idea with these is basically the panic disorder mimics a heart attack. All right, and remember from the previous discussion we talked about this idea, well, you can't simply say, well, the individual's having a panic disorder until you've actually taken the opportunity to rule out whether or not it's a cardiac episode, okay? So you have these individuals that come into the emergency department complaining of chest pains. They'll describe like it feels like an elephant is sitting on my chest. I feel like I'm going to die. All right, but you run cardiac enzymes, you run various different labs, and what do you find out? Well, there's absolutely no evidence on the ECG, all right, of there being some type of heart attack. Consequently, we turn to it being a panic disorder. Okay. Now, anxiety is a component of both disorders, okay, but we get anxiety more often than panic disorder, okay. What is the result of that? Well, if we can help people identify what it is that causes the panic attacks, all right, then we can help the people avoid the situation, avoid the triggers that are causing it as a form of treatment. Whereas with a generalized anxiety disorder, since we can't identify an underlying cause, well, then we can't tell the individual to avoid those situations. All right, the phobias, all right, we all have fears, all right, we all fear heights or snakes or spiders or blood or speaking in public or whatever it happens to be, okay, we all have something that we're afraid of, but once again, most of us can overcome that fear. If a person has a fear of heights, they might still be able to ride in the glass elevator down at Tattoo City. If they have a fear of flying, they can probably still get on the plane without feeling like they're going to have a heart attack. If you have a fear of speaking in public, you can still get up and give a presentation to get a grade in your class. Okay, that's normal fear. People with phobia have a persistent irrational fear that prevents them from functioning. All right, the person with a phobia of speaking in public simply can't get up and speak in public. Now remember, the idea behind a lot of these things like the anxiety disorders is that they're afraid of embarrassing themselves and that they won't be able to make a hasty enough exit. So the fear of a phobia of public speaking, in which it actually prohibits you from speaking in public, is a fear that you will embarrass yourself to such an extent that it will cause you great harm professionally or personally. Okay, so a couple of different phobias down there. If you look at the The larger bar, I guess we would describe that as closer to a purple color as opposed to the blue color, is a fear. And as you can see, a large number of individuals have fears of different things, such as being alone or storms or water, closed spaces, flying, blood heights, animals, etc., etc., etc. And a small percentage of everybody who also, of those individuals who have a fear, are actually going to be classified as having a phobia, because once again, the phobia is such that it interferes with their ability to function. So we all have fears, once again, like that line down the center of the classroom. We all have fears, but phobia is crossing over that line and remaining too long on the other side and impacting your ability to function. All right, so let's go through a couple of different kinds of phobias really quick. All right, agoraphobia, really one of the more common ones is simply a phobia of open spaces. Most people have a fear of open spaces because they fear they're going to do something silly and embarrassing, and because it's such a large open space, they're not going to have any place to get away and hide in. All right. Acrophobia, think about acrobats, it's simply a phobia of heights, all right? A lot of us are afraid of heights, all right? But we still can climb staircases, we can still ride the elevator, we can still get in the airplane. Not so with phobias, okay? Claustrophobia, phobia of closed spaces, okay? And hemophobia, a phobia of blood. There's a wonderful television series, it's a British television series called Doc Martin, and it's about a gentleman who is a surgeon in London. He's a very successful surgeon, and then one day he goes in to perform an operation on a woman, all right, and he doesn't see the woman as a pathology. Right? Suddenly he sees this woman as somebody's grandma, somebody's mother, somebody's wife, somebody's whoever it happens to. He sees this as an individual, and he suddenly develops this intense dread of actually operating for fear of doing something wrong. All right, he channels that fear into a fear of blood, and what it ends up doing is it ends up costing him his career as a surgeon. He has to go work in a small town in Cornwall as a general practitioner, and it's sort of a, I guess you would call it a dramedy, a comedy slash drama, but it's a great show in terms of illustrating this fear of hemophobia and how it truly interferes with his ability to function and continue carrying on his career, and how he has to change careers or at least specialties because of this phobia. Great, go out and download the torrent of it. All right, so that deals with phobias. Let's talk about obsessive compulsive disorder, also known as OCD. OCD is frequently made fun of in the media, all right? It's frequently made fun of among ourselves. You know, you look at an individual that has to have a specific study schedule, or they like to, you know, Mondays I study this class, Tuesdays I study this class, and they're extremely highly organized. What do? We laugh. We go, oh, for OCD, all right? So we make fun of it, but in truth, it is an honest-to-goodness psychological disorder that has serious consequences for individuals, all right? So and there's a compulsive side. The obsessive side are simply a persistence of unwanted thoughts, okay? Unwanted urges, all right? And because they're unwanted, we develop this desire to engage in the compulsions to deal with the distress that is caused by the obsessions, okay? Let me give an example. Let's say you're sitting watching TV one night and you're watching the news, and a show comes on about a house over in the West that burned down. And they say, the fire marshals say the house burned down because there was faulty wiring in the house. Well, maybe you don't think it's going to affect you, but all of a sudden you start to think to yourself, wow, what if the wiring in my apartment? All right, I'm a student, I don't live in a really great place here, what if the wiring's bad? And you start to obsess about this idea that the wiring is bad in your house, and it's brought on by this incident that might have happened hundreds of miles away that has nothing to do with you. But you think about it, you obsess about it to the point where it becomes really an unwanted thought, all right? And it's worrisome to you. So what do? You decide to come up with a little ritual, all right, to deal with these unwanted thoughts, all right, to banish the negative feelings that come from thinking constantly about your apartment burning down. So for whatever reason, you decide that if I flip the light switch on and off, click, 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 50 times every time I leave the house, all right, that's going to make sure that the house doesn't burn down. So the obsessive thoughts have given way to a compulsion, all right? Fear of the house burning down is the obsession. The compulsion becomes flipping the light switch on and off 50 times, okay? Now the thing is, like it says there, is it's a senseless ritual. Now remember Mark, our example at the beginning of the lecture. The people with OCD, at first it relieves the tension. All right, it relieves the irritation that comes from these unwanted thoughts. But with time, they come to realize how ridiculous it is. Well, isn't this stupid to think that me flipping the light switch on and off 50 times before I leave the house, that's not going to keep my house from burning down. But the problem is now the obsessions have given way to the compulsion, and they're out of control. All right, and now not only is the obsession causing unwanted distress, the compulsion is causing unwanted distress, but the person simply cannot quit doing it. So we've got the obsessive side, we've got the compulsive side, and it's like a reinforcement of each other. It goes round and round in a circle. Okay, let's look at this chart down here really quick. Here's some common obsessions or repetitive thoughts. About 40% of people with OCD are concerned with dirt and germs. Okay, so what's the compulsion? You jump down to the next line there. The compulsion is what they do. They wash their hands repeatedly. All right, they clean the bathroom repeatedly. They brush their teeth. They groom themselves repeatedly. All right, as a way of dealing with this obsessive thought or concern with dirts and germs and toxins. Okay. Second one there, something terrible is going to happen. Like the example we just had, about 24% of people report that. So what do? They have a repetitive ritual. They come in and out of the house 20 times. They touch the door handle 15 times. They make sure the doors are locked 20 times before they go to bed because they fear if they don't do that, someone's going to break in and kill their family. All right. So there's the obsession leading to the compulsion. All right. Then there's the idea of symmetry or order or exactness. Okay, that's only about 17% of individuals that have to have things exactly the way they want them. Okay. So that's the thought or the behavior leading to the compulsion. Constantly aligning the notebooks on their desk, constantly checking their backpack to make sure that they've got their cell phone and their calculator and they've got all the pencils and the pens that they need for that day. Okay? So an obsession leading to a compulsion. Okay. Now it's important to understand two other things here, and these are separate. We have what we call obsessive compulsive traits. Obsessive compulsive traits. Okay. Obsessive compulsive traits are not actually a disorder. They are simply a person who is very organized, likes to have things exactly the way they want them. Now, the interesting thing, and you all know someone like this, and maybe you actually are that individual, all right? I'm a little bit this way. Before I leave the office in the afternoons, I have to make sure that the computer is turned off and that the paper is all put in the appropriate folders and that my pens and my pencils are put away. And my wife, Amy, who shares the office with me, is completely different. She can just leave things the way they are. Paper is scattered everywhere, all right? Now, we're equally effective at doing our job, but I would probably say I have a little bit more obsessive-compulsive trait because I like things a specific way. Now, when we look at studies of individuals with obsessive-compulsive traits, what we find is that they tend to be higher achievers. So the more educated an individual is, the more achieving they are in terms of life, the more likely we are to find that they have some of these obsessive-compulsive traits. So if you're here and you're doing well in dental school and you know that you're here because you scored high on the exams and that means somebody else didn't get in, maybe you have obsessive-compulsive traits. Okay. The other thing that we need to differentiate here is what we call obsessive-compulsive, and I'm going to insert a different word here, personality disorders. So we have OCD, and then we have obsessive-compulsive personality disorder. Now, the personality disorder, and we don't talk much about them in this lecture, are a whole classification of diseases, of psychological, psychiatric diseases. And what characterizes them is that because they're a personality disorder, that's just how the individual is. They've been that way since birth, all right? They have a rigid, inflexible attitude towards the world around them, and it's always been present, okay? Now, how does that differentiate from OCD? Remember what I said about OCD is a lot of times it comes about because of some type of event. In the example we gave, where the individual had to flip the light switch on and off 50 times because they were afraid the house was going to burn down, it was because they watched a news report about a house that burned down over in Latoka or something like that. All right? So it isn't something the person is born with. It comes about because of some type of traumatic or unusual episode that they have in their lives. Okay, so we have OCD, we have obsessive compulsive personality disorder, and we also have obsessive compulsive traits. And they're three different things. The only one that is truly, well, excuse me, OCD is considered pathological, and so is obsessive compulsive personality disorder. So the only one that is not considered pathological is obsessive compulsive traits. All right. So I mentioned when we were discussing etiology of these things that they are what we call organic disorders. So in other words, we have the ability to see some type of biochemical change in the individual. So a lot of times what we see is we can do what we call PET scanning. PET scanning is similar to CT scanning. It's called positron emission tomography. Okay, but instead of like a CT scan that gives us sections, imaging sections of brain in black and white, where we can look for strokes or we can look for whatever it happens to be. The PET scan gives us an image of activity in the brain, all right? So if you look at this PET scan off to the right here, what you see is that the images in dark red are where we see the highest rates of metabolic activity. So in other words, these are the areas that are most active. And you see from this image here, we have an individual with OCD. So this is a PET scan. And what we see is that there's in the frontal lobe, which would be towards the top of the picture there, we see a lot of metabolic activity. Now, the frontal lobe is involved in decision-making, interpersonal relationships, organizing, all right, and directing our attention, all right? So in the individual with OCD, when we do a PET scan, we see that that area of the brain is very, very focused, very, very active, all right? And it's active because it is thinking about those obsessions consistently and trying to resolve a way to deal with the negative emotions that come with those obsessions. So in other words, thinking about engaging in the actual compulsions, okay? So a non-OCD person would not have this high level of activity in that frontal cortex of the brain, okay? Now, conversely, if we were to look at an individual with obsessive compulsive traits, we would also see that the frontal lobe, which is, like I said, involved in executive functioning and organization and things like that, would probably be a little bit more organically active than an individual who didn't have obsessive compulsive traits. All right, so we've done OCD. So let's talk about PTSD, post-traumatic stress disorder. Basically, PTSD is 4 or more weeks of the following symptoms constitute a diagnosis of PTSD. Haunting memories, nightmares, social withdrawal, jumpy anxiety, and sleep disorders. Now, the thing to understand about PTSD is brought about by any type of abnormal experience outside the realm of human experience. Now, we tend to think of OCD, as the picture indicates off to the right there, as being associated with soldiers, all right, serving in combat zones, seeing people blown up because of improvised explosive devices, seeing just the real negative, disastrous sides of war, okay, because that's clearly outside of the normal range of human experience. It's important to understand that anyone, all right, can have PTSD. A police officer can have PTSD. A paramedic who works on an ambulance, all right. A person who is kidnapped, or a person who is involved in a hostage scenario, or a bad automobile accident, or sees a friend overdose and die, or even anything that is outside of what we might consider normal human experience can result in PTSD. And like I said, we've got the symptomologies there. Haunting memories, they tend to relive the event over and over and over again, both by thinking about it, so in that way that it actually becomes an obsession, similar to OCD, okay? But they also tend to do it in their dreams. They have nightmares, all right? We'll talk to soldiers who have come back from Iraq and Afghanistan and areas like that, and they'll have dreams about a bomb going off along the side of the road, and they'll watch it in their nightmares over and over again in slow motion. Not surprising, because of this, they are socially withdrawn. They don't enjoy being around their friends anymore. They don't enjoy being around their loved ones. They don't enjoy doing the things that they used to like to do. So in that way, it's very similar to depression. And in fact, it's not uncommon that the individual with PTSD also is going to suffer from unipolar depression. And it's also not uncommon that these individuals, because they're having such negative experiences, they will turn excuse me, they will turn to alcohol as a way of trying to deal with the emotions before they seek professional help. All right. So it's not uncommon for PTSD patients to be not only suffer from PTSD, but also to have substance abuse disorder and also to have depression as well. Okay. A lot of times have anxiety disorder too to go with it. So it's a very multimodal, multi-diagnostic area. All right. They also have what we call jumpy anxiety. So if you've had an individual that saw a bomb go off in which their best friend was killed, it might be that they hear a car backfire in traffic, and that sets off a memory of it. All right, they're constantly looking around, looking behind themselves, all right, because they're worried about these things. And it's not surprising that they have difficulty sleeping as well. Okay, that can come on both ends of the spectrum. It can be insomnia, in which they can't get to sleep, or if it is associated with depression, it can be too much sleep. Right? They might want to spend all of their day sleeping as a means of handling that. All right, so resilience to PTSD, all right, so our ability to essentially fight it off. Only about 10% of women and 20% of men react to traumatic situations and develop PTSD. So it's actually a small percentage of individuals. And if you look at that, what's interesting is about half the number of women experience PTSD as opposed to the men. So maybe it is that women handle anxiety and stress better. And that's true. We actually do know that one difference between men and women that has a role both in rates of depression and in rates of PTSD between the two genders is that women tend to utilize their social networks better. They're willing to speak with friends and family and professionals, all right? So they're doctors, they're psychologists, and are more willing to seek assistance than are men. Men tend to, once again, take these nasty little emotions that we have and we bottle them up and we stuff them deep inside and we go, no, I'm a man. I'm not going to talk about my emotions with some type of head shrink down at the clinic. All right. So that's one of the reasons that we see the difference in terms of resilience to PTSD. Okay. Holocaust survivors have remarkable resilience to PTSD. When I refer to the Holocaust, I'm talking about the individuals who were placed in the Nazi concentration camps during World War II, where they were subject to some of the worst, most atrocious situations. In fact, there was a gentleman named Viktor Frankl, famous psychiatrist that was Jewish, and he spent some time in the concentration camps. He wrote a book called Man's Search for Meaning, and he also developed a type of therapy called logotherapy. And basically what Dr. Frankl saw was he saw everybody around him simply giving up in the concentration camps, and he noticed that when they gave up, it wasn't very long until they actually just died. And so his decision was, he goes, they can take away my physical freedom, and they can tell me what time to get up and much, I need to dig a hole today or I need to break up rocks today. But he goes, they can take away my physical freedom, but he goes, what they can't take away from me is my mental freedom, my ability to decide how I'm going to react to the situation. And so he attributed his survival in concentration camps to this attitude of his. And many of the Holocaust survivors simply had the attitude that essentially it was God's will in terms of the suffering that they were going through. And so consequently they had a greater resilience to PTSD. Okay. Basically what it comes down to, if you look at major religions of the world, almost all religions of the world have this attitude of, well, you were put here on earth and you're going to have certain experiences, and some of them are going to be traumatic, but they are learning, they're growing experiences. So we know that a lot of this resilience to PTSD has to do with what is your attitude towards the suffering, all right? Is it that you believe the suffering has purpose, or it doesn't have to be a religious purpose, it can just be looking at the world in a certain way, a certain philosophy. And if you remember the Holmes and Ray scale of traumatic life events that we talked about earlier in the semester, it was the same thing. Individuals were more resilient to depression and anxiety if they had a system of belief, a way of framing their particular suffering. Okay? All right, so how do we explain the anxiety disorders? We've already talked about Freud's suggestion that we repress our painful and intolerable feelings and thoughts, and that results in anxiety. Remember, that was you forget what you forget, or you forget and then you forgot what you forgot, okay? And then once again, this idea that we repress the thoughts is that we're unconsciously not able to forget them, and the unconscious pain continues to cause us anxiety, all right? But because we don't recognize the subconscious source, we can't deal with it directly. Remember we talked about this when we did the defense mechanism lecture. So this is why individuals who have anxiety disorders are oftentimes asked to undergo psychotherapy as a means of uncovering what it is that is the root cause of the anxiety. Okay, so in terms of explaining the anxiety disorders, let's take a look at this idea of what we call the learning perspective. All right, this would be the social in the biopsychosocial model. So we have what we call observational learning, and if we look at monkeys, we know that they learn fear because they watch their parents. All right, they watch their parents have a fear of snakes. They watch their parents have a fear of other types of predators, and consequently, that's how the monkey learns it. So what situations do we teach our children? Well, we teach our children to be afraid of danger in terms of strangers. We teach our kids to look both ways before crossing the street. All right. So this idea that we can learn fears, all right, is also present in this idea of the anxiety disorder. We learn to fear certain things. Consequently, sometimes we take those fears to too great an extent. Okay, and it becomes an anxiety disorder. Okay. There's all biological perspective here as well. So once again, the biopsychosocial model at work here in this idea of natural selection. So in other words, why did our ancestors learn to fear snakes and spiders and other animals? Well, they learned to fear those things because it was a protective factor. If our caveman ancestors learned that at nighttime you locked yourself up in the cave and you rolled a big rock in front of the door, then you didn't get eaten by the saber-toothed tiger. Those who didn't learn that lesson did get eaten by the saber-toothed tiger, and they couldn't propagate the species. It was the individuals who did learn, all right, that were then able to go on and breed and become our progenitors. Okay, so natural selection plays a role in terms of this. If we learn fears, these fears are then passed along genetically. Okay, we can also see this in twin studies. A lot of the studies that we do in psychology looking at human behavior, we love to use twins because they're remarkably alike in terms of their genetics. All right, and what do we find is that twins are more likely to share phobias, for instance. Okay, more likely to share fears and anxiety because of the genetics, because of the natural selection that is present there. So once again, in terms of looking at the development of the anxiety disorders, it's both biological, psychological, and social in terms of its development.